what's up? I hope we are live now. Please thumbs up दे दो फटाफट से. Are we live? Are we live? Are we live? Are we live or not? So let's see. Wait a second. Let me bring my iPad once. एक second. I think we are live or not. It's not showing us live. Why? Yeah. Yes, we are live again, and this is the third session. Yeah, and this is the third session of a heart in which we will be in which we will be doing the heart IHD basically, ischemic heart disease. इस्कीमिक हार्ट डिजीज़ करेंगे, MI करेंगे, एंजाइना करेंगे, उनके माइक्रोस्कोपिक फीचर्स देखेंगे and all of that. But wait a few seconds and yes, wait. Yes. So guys, how are you all? I hope that you all are doing good, you all are well, you all are fighting for your goals. I hope. What's wrong with this man? What's wrong with this man? There is some error in the live chat. I don't know what's wrong with this. फटाफट से क्लियर हो जा. I don't know what's the error. I am really sorry, but error आ रखा है यहाँ पर एक, and I am just looking for a how we can treat this error. Yeah, now I think it's probably fine. Yeah, now I think it's fine. And ये मेरे बालों के ऊपर क्या लगा पड़ा है. So guys, welcome to Unacademy, the best online learning platform, and here we are studying systemic pathology. I am Shiv Virmani, Indian medical student and author of the book Pharmac Easy, and I am publishing my second book soon. My second book will be released on 25th December, and yeah, let's just get started. On Unacademy, we are having top level of educators, and how you can enroll to their batch courses. You have to install the Unacademy app. You can install it on your iPad or your phones, mobile phones, and it's a free app. You don't have to pay a single penny if you want to install it. And even if you even you can attend the special live classes, and that's the benefit. You can chat with your educator for free. You can clear your concepts for free, and you can take its benefit for free. But if you want to buy the plus course, and if you want to join the batch courses of the top level of educators from the AIMS, Safdarjung and all the esteemed universities, then you have to buy the plus course. And if you want to buy the plus, then you must be knowing the benefits of the plus. So plus course के अंदर you can attend the live classes, you can attend the live test, you can take up the quizzes, where you will be knowing your negative points and your positive points, and you can enroll in your various batch courses. Plus you get a structured schedule. It means that you get a strategy, and with this strategy you will be clearing your exams easily, right? So that's the very good benefit of the plus course, that you get a structured schedule or a strategy. And strategy कौन देता है? Strategy is provided by the top level of educators. And iconic course, now let's talk about iconic course. This is the new course of and this course is the collaboration between the Unacademy and the Prep Ladder. So all the benefits you get, so you get all the benefits of Unacademy here. You can attend live classes, you can attend or take up the live test, you can take live quizzes, you can enroll yourself into various batch courses, you get the strategy. Plus you can so इसके अंदर तो आप Unacademy full आप access कर सकते हो. Plus here you get Prep Ladder वाले सारे benefits. You can you can view the or you can learn from the pre-recorded video lectures of Prep Ladder. You can take up the Q Bank, or then Q Bank 2.0, then Rapid Revision Course 2.0. So plus you get the handwritten notes. So iconic course is best for a first, second and a third year medical student. And yeah, you should refer to this course. I would suggest this course to you. Then the plus course. Then if you want to buy iconic course, then you have 4 choices. You can buy it for 12 months, you can buy it for 18 months, you can buy it for 24 months, and you can buy it for 36 months. And yeah, and code if you want to buy, and you will be getting 10% off if you will be using Virmani as the referral code. You will be getting instant 10% off. Then plus course. Plus course के अंदर you have many choices. You can buy it for 1 month, 3 months, 6 months, 12 months, 18 months, 24 months and 36 months. And you are confused कि should you buy this or not. ठीक है, value for money है नहीं है. Then you should buy it for only 1 month. So 1 month आप try करो. 1 month पे you have to pay only 4500 after discount. और so daily का आपका हो गया only 150 rupees. So daily हम 150 तो ऐसे ही खर्च कर देते हैं. और after spending this 4500 you can so you get a gate pass, and you can control full or whole Unacademy. You get the access to enter into any batch course, and every batch course you can attend. You can chat with the any educator, right? So काफ़ी ज़्यादा benefits हैं इसके, जैसे कि हमने डिस्कस करे. और just for the testing purpose you can buy it for 1 month, right? And if you liked it, then you can upgrade it to the 12 months or 24 months or 36 months as per your need. Yeah, so and code is same Virmani, or even if you can upgrade it to iconic as well. So iconic के लिए भी आप upgrade कर सकते हो. So that's the main benefit. Or testing के लिए you should buy at least it for 1 month, and yeah, it will be a value for money spending of your. So काफ़ी ज़्यादा valuable for money है ये, right? So let's just move further. Welcome to PathoNION, the pathology companion, and here we study the pathology and its concept, and we try to learn pathology very easily, or we try to make our concepts clear, like we have done in pharmacology wala session mein, pharmac easy mein. So pharmac easy was a pharmacology series. So we have almost done around 50 to 60 sessions of द फार्माकोलॉजी, जिसके अंदर कुछ शॉर्ट सेशंस भी हैं, कुछ वेरी वेरी लॉन्ग सेशंस भी हैं, MCQ सेशंस भी हैं, सम अप सेशंस भी हैं, एंड दीज आर रियली वेरी 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 बेनिफिशियल सेशंस फॉर स्टूडेंट जिसको फार्माकोलॉजी डिफ़िकल्ट लग रही है, जिसको कॉन्सेप्ट्स बनाने हैं, जिसको नॉट ओनली सिर्फ एग्ज़ाम क्लियर करना है, बट जिसको MCQ एग्ज़ाम में भी अच्छे मार्क्स लाने हैं, और जिसको ट्रीटमेंट भी अच्छे से करना है, राइट? सो हमने अच्छे से डिस्कस करके फार्माकोलॉजी पढ़ी है. सो तीनों चीज़ों में बेनिफिट होगा इस चीज़ का और इस सीरीज़ का, राइट? सीरीज़ का नाम है फार्मैक इजी. सो प्लेलिस्ट में भी आपको मिल जाएगी ऑन द अनअकैडमी, एंड इवन इफ़ यू गूगल सर्च इट तो आपको मिल जाएगी. प्लस आपको अनअकैडमी ऐप पर भी उसके कुछ सेशंस मिलेंगे, एंड या आई वुड रेफर टू दैट. सो एज अ मेडिकल स्टूडेंट आई प्रेफर कि आप वो ज़रूर वो वाली सीरीज़ देखो. प्लस एक प्लस कोर्स भी है, प्लस कोर्स इज़ ऑल्सो देयर दैट. सो फार्मैक इजी का ही प्लस कोर्स है, एंड वी हैव स्टडीड होल एंडोक्राइन in the 9 sessions, and एक quiz है उसके बाद, and that's the very 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 best thing for the for a second year medical student as well as after the second year वालों के लिए भी, post second year medical student के लिए भी काफ़ी ज़्यादा beneficial चीज़ है. And let's just jump to our topic, the ischemic heart disease. So here we will be discussing the ischemic heart disease. Wait a second, where have you gone? So guys, in the morning wala session we have completed the heart failure, and here we are there to complete the ischemic heart disease. We will be completing the ischemic heart disease. And hi guys, what's up? So I hope you all are fine, you all are healthy, you all are well, and here we will be doing the ischemic heart disease. We'll be completing the ischemic heart disease, and in the morning wala session we have already completed the heart failure. We have discussed the classifications of the heart failure, the right heart failure, the left heart failure, and the backward heart failure, forward heart failure, plus wait a second, yeah, then we have all also discussed the remodeling processes and the morphological features and all, right? So that's the very 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 beneficial session, and you all must refer to that session. And here we will be studying the ischemic heart disease. I hope I am audible and visible. Yeah, we are audible and visible. So let's just start the ischemic heart disease, guys. हमने इसका progression सुबह पढ़ लिया था. So how the disease is progressed. So basic or the main etiological factor is atherosclerosis. Due to atherosclerosis, a patient will be developing a coronary artery occlusion, and due to a coronary artery occlusion or due to the decreased supply of oxygen or nutrients, there will be angina. Angina is demonstrated by a typical chest pain that will be radiated to the left arm and the back and the left side of the jaw, and patient will be having the palpitations or sweating and all, right? And if angina is not treated, or if we will be not giving the treatment to a patient that is undergoing angina, then he or she will be end up in myocardial ischemia, and myocardial ischemia will further end up in myocardial infarction. Then this myocardial infarction ultimately chronic ischemic heart disease में convert हो जाएगी. So guys, ischemic heart disease is defined as the acute and the chronic form of cardiac disability arising from the imbalance between the myocardial supply and demand for the oxygenated blood. Since narrowing or obstruction of the coronary arterial system, it is the most common cause of the myocardial anoxia, and the alternate term is there, that is coronary artery disease, and it is used synonymously with the IHD. And IHD or the CAD is the leading cause of the death in most of the developed countries, because in the developed countries people try to eat more and more of fat, so their coronary arteries are occluded and thus they die. And somewhat low incidence is observed in the developing countries. Men develop IHD earlier than women, and postmenopausal women are basically postmenopausal women के अंदर there is the development of IHD, and जो menstruating women होती हैं उसके अंदर नहीं होता because of the estrogen, and men में it develops earlier because of estrogen वाली things. Estrogen नहीं होता men में, और if it is there then very less amount, very less amounts में as compared to women, ठीक है. So as per the rising trends, it is estimated that इस साल 2020 तक it would become the most common cause of death throughout the world, but now in 2020 we are having coronavirus, that is the leading cause of death. Then etiopathogenesis. IHD is invariably caused by the disease affecting the coronary arteries, and the most prevalent being atherosclerosis. So atherosclerosis is the most common etiological factor that is causing the ischemic heart disease, and that is accounting for more than 90% of the cases, while other cases are responsible for less than 10% of the IHD. Therefore, it is convenient to consider the etiology of the IHD in the three broad headings. First is coronary atherosclerosis, then the superadded changes in the coronary atherosclerosis, then non-atherosclerotic causes, and the non-atherosclerotic causes are very least etiological factors that cause the ischemic heart disease. Main are atherosclerosis or the superadded changes, because atherosclerosis के बाद अल्सरेशन हो सकते हैं, थ्रोम्बोसिस फॉर्मेशन हो सकता है, एम्बोलाई वहाँ से निकल सकता है, डिसेमिनेट हो सकता है, एंड दैट आर द मेन कॉजेज जिसकी वजह से IHD होने के चांसेस होते हैं. So coronary atherosclerosis results into the fixed obstruction, and this is the major cause of IHD in more than 90% of the cases. And the general aspects of the atherosclerosis are as regards its etiology, pathogenesis, and the morphological feature of the atherosclerotic lesions have already been dealt with at length in the proceedings, and here we are doing a brief account. So we have already done the atherosclerosis in our blood vessel and disorder wala chapter. That was the lesson or the session that we have done day before yesterday, right? And or yesterday, I think day before yesterday, I don't remember. Yeah, do check it out in the series, or you can search it on the YouTube as well. आप लिखो उसके अंदर पैथोनियन ब्लड वेसल डिसऑर्डर और शिव विरमानी ब्लड वेसल डिसऑर्डर, ऐसा कुछ लिख दो तो आ जाएगा. एंड फर्स्ट इज distribution. Atherosclerotic lesion in the coronary arteries are distributed at one or more of the three major coronary arterial trunks, and the highest incidence being in the anterior descending branch of the coronary LAD, followed by the decreasing frequency and by the right coronary artery, and still less in circumflex branch of the left coronary About one third of the cases have single vessel disease and most often left anterior descending and arterial involvement. Another one third have two vessel disease and the remainder has three major vessel disease. Second is location. Almost all adults show atherosclerotic plaques scattered throughout the coronary arterial system. But the disease is caused by the fixed atherosclerotic plaques. The atherosclerotic plaques in the coronaries are more often eccentrically located, bulging into the lumen from one side, and occasionally there may be concentric thickening of the wall of the artery. Atherosclerosis produces gradual luminal narrowing, and that may eventually lead to fixed coronary obstruction. And the general features of the atheromas of the coronary arteries are similar to those affecting elsewhere in the body and may develop similar complications like calcification, coronary thrombosis, ulceration, hemorrhage, rupture, and aneurysm formation. So, right. And superadded changes. So in coronary atherosclerosis, the attack of the acute coronary syndromes, which include acute MI, unstable angina, and sudden ischemic death, are precipitated by certain changes superimposed on the pre-existing fixed coronary atheromatous plaque, and these changes are as under. First is acute changes in the chronic atheromatous plaque. Though chronic fixed obstructions are the most frequent cause of IHD, and acute coronary episodes are often precipitated by sudden changes in the coronary plaque, such as plaque hemorrhage, fissuring, or ulceration that result in the thrombosis and embolization. And of the embolization of the atheromatous debris, and acute plaque changes are brought about by the factors such as sudden coronary artery spasm, tachycardia, intraplaque hemorrhage, and hypercholesterolemia. So these are the superadded changes. And coronary artery thrombosis. So coronary artery thrombosis, transmural acute myocardial infarction, is often precipitated by the partial or the complete coronary thrombosis, and the initiation of the thrombus occurs due to the surface ulceration and of the fixed chronic atheromatous plaque, and ultimately causing the complete luminal occlusion. And the lipid core of the plaque in particular is highly thrombogenic. Small fragments of the thrombotic material are then dislodged, which are embolized to terminal coronary branches and cause the microinfarcts in the myocardium. Then local platelet aggregation and the coronary artery spasms. So some cases of the acute coronary artery are caused by local aggregates of the platelets on the atheromatous plaque. Short of forming a thrombus, the aggregated platelets release vasospasmic mediators such as thromboxane A2, which may probably be responsible for the coronary vasospasm in the already atherosclerotic vessel. And non-atherosclerotic causes. Several other coronary lesions may cause IHD in less than 10% of the cases, and these are as under. First is vasospasm. So it has been possible to document the vasospasm of one of the major coronary arterial trunk in the patient with no significant atherosclerotic coronary narrowing, which may cause angina or MI. Then stenosis of the coronary ostia. So coronary ostial narrowing may result from the extension of the syphilitic aortitis and from the aortic atherosclerotic plaque and encroaching on the opening. And arteritis. So various types of inflammatory involvement of the coronary arteries or the small branches, like in rheumatic arthritis, polyarteritis nodosa, thromboangiitis obliterans, Perker's disease, Takayasu disease, Kawasaki disease. Then tuberculoid arteritis and other bacterial infections may contribute to the myocardial damage. And embolism. Rarely emboli originating from the elsewhere in the body may occlude the left coronary artery and its branches and produce IHD. The emboli may originate from the bland thrombi and from vegetations or the bacterial vegetations of the bacterial endocarditis, and rarely fat metabolism and the air metabolism of the coronary circulation may occur. Then the thrombotic diseases. Another infrequent cause of coronary occlusion is from hypercoagulability of the blood, such as in shock, polycythemia vera, sickle cell anemia, thrombotic thrombocytopenic purpura. एंड ट्रॉमा की बात करें देन contusion of a coronary artery from penetrating injuries may produce thrombotic occlusion. And aneurysm, extension of the dissecting aneurysm of the aorta into the coronary artery may produce thrombotic coronary occlusion. And rarely congenital mycotic and syphilitic aneurysm may occur in the coronary arteries and produce the similar occlusive effects. Then compression of a coronary from outside by a primary or a secondary tumor of the heart may result in coronary occlusion. And progression. So initially when there is the progress of atherosclerosis, so जब atherosclerosis हो रहा होता है तब patient is asymptomatic. So patient is asymptomatic, right? बट जब एथेरोस्क्लेरोसिस हो जाता है, ऑक्लूजन हो जाता है एंड द O2 सप्लाई इज़ लेस, एंड जब भी ये O2 सप्लाई लेस होती है तो क्या क्या दिखेगा आपको? O2 सप्लाई लेस होने के कारण patient will be having angina वाले symptoms, and he or she will be having the chest pain that is radiating to the left side, that is radiating to the left arm, that is radiating to the left side of the jaw, that is radiating to the back side, and there is palpitation, sweating, right? And so these are the specific characteristic features of an angina. And अगर patient को emergency treatment नहीं मिला then he or she might end up in the ischemic damage of the myocardium. Myocardium का ischemic damage हुआ then he or she might undergo acute myocardial infarction. Then this acute myocardial infarction further it can cause chronic ischemic heart disease, ischemic cardiomyopathy, myocardial fibrosis, and sudden cardiac death. So this is a disease progression of ischemic heart disease. Then the term acute coronary syndrome include the triad, and triad consists of the three, as it is triad, so it will be consisting three characteristic feature. So the triad is of acute myocardial infarction, unstable angina, and sudden cardiac death. Then angina pectoris. Angina pectoris is a clinical syndrome of IHD resulting from the transient myocardial ischemia, and it is characterized by paroxysmal pain in the substernal and precordial region of the chest, which is aggravated by an increase in the demand of the heart, and it is relieved by a decrease in the work of the heart. And often the pain radiates to the left arm, neck, jaw, and right arm as well, but in the rare chances. And it is more common in men past 5 decades of the life, and there are overlapping clinical patterns of angina pectoris with some differences in the pathogenesis. So there are three types. You can say there are three types of angina: stable or typical angina, prismental or variant type of angina, or vasospastic type of angina, and third is unstable or crescendo angina, right? These are the three types of angina. And first of all, stable or typical angina. So stable or typical angina, this is the most common pattern, and the stable and the typical angina is characterized by the attacks of the pain following the physical exertion or exercise, right? Exercise, physical exertion, emotional excitement, right? So तब इसके symptoms आएंगे, and once you take the rest और रेस्ट लेने के बाद वो चीज़ सबसाइड हो जाएगी. एंड द पैथोजेनेसिस ऑफ द कंडीशन लाइज इन द क्रोनिक स्टेनोजिंग coronary atherosclerosis that cannot perfuse the myocardium adequately when the workload on the heart increases. During the attacks, there is depression of the ST segment in the ECG due to the poor perfusion of the subendocardial region of the left ventricle, but there is no elevation of the enzyme in the blood as there is no reversible myocardial injury, right? And prismental variant angina, this pattern of the angina is characterized by pain at rest and has no relationship with physical activity, and the exact pathogenesis of the prismental angina is not known, right? is not known, and it may occur due to the sudden vasospasm of the coronary trunk induced by the coronary atherosclerosis, or may be due to the release of the humeral vasoconstrictors by mast cells in the coronary adventitia. ECG shows the ST segment elevation due to the transmural ischemia, and these patients respond very well to the and vasodilators and like an nitroglycerin and sorbitrate. So we have already discussed these things in our pharmacology series. Unstable or crescendo type of angina, so also referred as pre-infarction angina or the acute coronary insufficiency, right? So it is also called as acute coronary insufficiency. This is the most serious pattern of the angina, and it is characterized by more frequent onset of pain of prolonged duration and occurring often at rest. It is thus indicative of an impending acute myocardial infarction. Distinction between unstable and acute MI is made by ST segment changes on the ECG. Acute MI characterized by ST segment elevation, while unstable angina may have non-ST segment elevation MI. So unstable angina will be having non-ST elevation MI, right? So I hope it is fine, right? Is it fine? Is everything is okay? अगर कुछ समझ में नहीं आ रहा, then you can ask in the chat. चलो ठीक, everything is fine, everything is looking fine. Then multiple factors that are involved in the pathogenesis of the unstable angina, which include stenosing coronary atherosclerosis, complicated coronary plaques, superimposed thrombosis, hemorrhage, rupture, ulceration, so platelet thrombi over atherosclerotic plaques, and vasospasm of the coronary arteries. Most often, the lesions lie in the branch of the major coronary trunk, so that collaterals prevent infarction. Acute myocardial infarction. So guys, acute myocardial infarction is the most important and the feared consequence of the coronary artery disease. Many patients may die within the first few hours of the onset, while remainder suffer from the effects of the impaired cardiac function, and a significant factor that may prevent or diminish the myocardial damage is the development of the collateral circulation through the anastomotic channels over a period of time, and a regular and a well planned exercise program encourages good collateral circulation and improved cardiac performance. And incidence. So guys, in development, in the developed countries, MI accounts for 10 to 25% of all the deaths, and due to dominant etiological role due to the dominant etiological role of the coronary atherosclerosis in the acute MI, the incidence of the acute MI correlates well with the incidence of the atherosclerosis in the geographic area and age. Acute MI may virtually occur at all the ages, though the incidence is higher in the elderly, and about 5% of the heart attacks occur in young people under the age of 40, particularly in those with major risk factor to develop atherosclerosis like hypertension, diabetes mellitus, cigarette smoking, and dyslipidemia, including familial hypercholesterolemia. And now sex. Male predominance is there because males में एस्ट्रोजन नहीं होता है तो बहुत कम होता है, and male throughout their life are significantly at higher risk of developing acute MI as compared to the females. Women during reproductive period have remarkably low incidence of the acute MI, probably due to the protective influence of the estrogen. The use of the oral contraceptive is associated with the high risk of developing acute MI, and after menopause, this gender differences gradually declines, but the incidence of the disease among women never reaches that among men of the same age. Then etiopathogenesis. The etiological role of severe coronary atherosclerosis is one or more of the three. Wait a second, guys. Hello. हैं? मेरी तो अभी क्लास चल रही है, बोलो। क्या? क्या? पता नहीं। पता नहीं मेरे को, मैं तो क्लास ले रहा हूँ। ठीक है। The etiological role of severe coronary atherosclerosis, more than 75% compromise of lumen of one or more of the three major coronary arterial trunks in the pathogenesis of about 90% of the cases. So I'm really sorry for the phone call. Actually there was emergency and तो मैंने कहा था कि I have to take a class, but still उनका still my colleague called me and I'm really sorry. बट द कॉल वॉज इम्पॉर्टेंट, अदरवाइज अगर इम्पॉर्टेंट नहीं होती तो मैं नहीं उठाता, बट इट वॉज अ इम्पॉर्टेंट कॉल, सो दैट्स वाई. So a few notable features in the development of the acute MI are as under. So first is myocardial ischemia. Myocardial ischemia is brought about by one or more of the following mechanisms. First is diminished coronary blood flow, example in coronary artery disease and shock. Then hypertrophy of the heart without simultaneously increase of the coronary blood flow, example in hypertension, valvular heart diseases. And role of the platelets. So first of all, rupture of an atherosclerotic plaque exposes the subendothelial collagen to the platelets, which undergo the aggregation, activation and release reaction, and these events contribute to the buildup of the platelet mass that may give rise to the emboli and initiate the thrombosis. So first is atherosclerotic plaque is there, uska rupture hua, right, and subendothelial collagen expose ho jayega, so that is the main attracting factor to the platelets, or platelets आएंगे, they will undergo aggregation, activation and release reaction, and these even contribute to build up a platelet mass and that may give rise to emboli or a thrombus. Then acute plaque rupture. So in general, slowly developing coronary ischemia for stenosing coronary atherosclerosis of high grade may not cause acute MI but continue to produce episodes of the angina pectoris. But acute complications in the coronary atherosclerotic plaque in the form of superimposed coronary thrombosis due to the plaque rupture and the plaque hemorrhage is frequently encountered in the cases of acute MI. First is superimposed coronary thrombosis due to the disruption of the plaque and is seen in about half the cases of acute MI. And infusion of the intracoronary fibrinolysins in the first half of an hour of development of acute MI in such cases restores the blood flow in the blocked vessels in the majority of the cases. Then intramural hemorrhage is found to be about one-third cases of the acute MI, and plaque hemorrhage and thrombosis may occur together in some cases. Then non-atherosclerotic causes. About 10% of the cases of acute MI are caused by non-atherosclerotic factors such as coronary vasospasm, arteritis, coronary ostial stenosing, embolism, thrombotic diseases, trauma, and outside compression as already described. Then transmural versus endocardial infarcts. So इसकी हम photos अभी देखेंगे. These are some differences in the pathogenesis of the transmural infarct involving the full thickness. ट्रांसम्यूरल मतलब फुल थिकनेस, ठीक है, स्टार्टिंग से लेकर एंड तक, ठीक है. सो ट्रांसम्यूरल और द फुल थिकनेस ऑफ द वेंट्रिकुलर वॉल, एंड सब एंडोकार्डियल मतलब लैमिनार इन्फार्क्ट्स अफेक्टिंग द इनर सब एंडोकार्डियल, और दैट इज वन थर्ड टू द हाफ. So transmural or full thickness infarcts are the common type to be seen in 95% of the cases, and critical coronary narrowing is of the great significance in the causation of such infarct, and atherosclerotic plaques were superimposed thrombosis and intramural hemorrhage are significant in about 90% of the cases, and non-atherosclerotic causes in the remaining 10% cases. Then the subendocardial or the laminar infarcts have their genesis in the reduced coronary perfusion due to the coronary atherosclerosis, but without any critical stenosis, not necessarily 75% of the compromised lumen, and aortic stenosis or the hemorrhagic shock. This is because subendocardial myocardium is normally least well perfused by coronaries, and thus it is more vulnerable to any reduction in the coronary flow. Superimposed coronary thrombosis is frequently encountered in these cases too, and hence the beneficial role of fibrinolytic treatment in such patients is there. Then this is the picture that is showing transmural and the subendocardial or the laminar. So transmural मतलब full thickness, whole thickness. So starting से लेकर end तक, as you can see. So this is the transmural or right. So here you will be seeing a subendocardial as the name suggests, right? And lamina मतलब in between, right? So you can see subendocardial or laminar, they are in the same category, right? So types of the infarcts. So infarcts have been classified in the number of the ways by the physician and the pathologist according to the anatomical region of the left ventricular involved. They are called as anterior, posterior, lateral, septal, circumferential infarcts, right? So और ये चीज़ हम ECG में देखकर पता लगाते हैं that infarct is anterior or posterior or lateral or septal or circumferential, and their combinations like anterolateral, posterolateral and anteroseptal. So these are few combinations, and according to the degree of thickness of the ventricular valve involved, infarcts are of two types. One is full thickness, that is entire the thickness of the ventricular wall, and then subendocardial or laminar when they occupy the inner subendocardial half of the myocardium. Then third is according to the age of infarcts, they are of two types, right? So they are of two types, and the newly formed infarcts are called as acute and recent or fresh, and advanced infarcts are called as old, healed or organized. Then the coronary arteries that are affected. So first is left anterior descending coronary artery, right? Anterior descending coronary artery, and this is the circumflex branch. So mostly people are having the occlusions here, 40 to 50%, ठीक है? And right coronary artery में 30 to 40%. एंड ये है एंटीरियर एस्पेक्ट, और ये जो पीछे आपको दिख रहा है ये पोस्टीरियर एस्पेक्ट है, राइट? एंड ये है पोस्टीरियर इंटरवेंट्रिकुलर एंड राइट. सो ये है, ये जो जा रही है, दिस इज सर्कमफ्लेक्स ब्रांच ऑफ द लेफ्ट एंटीरियर आर्टरी. सो लेफ्ट सर्कमफ्लेक्स कोरोनरी आर्टरी बोलते हैं इसको, एंड इट इज़ एंड 15 to 20% ऑफ केसेस में ये चीज़ कॉज होती है. And here you have been seen the transmural and the subendocardial or the laminar infarcts, and accordingly intermediate, less common and most common. So most commonly ये affect होती है. Intermediately ये वाला segment जो posterior segment है, ये posterior है, ये anterior है, and this is lateral. सो लेटरल भी अफेक्ट होता है, इंटीरियर एंड ठीक है. और ये है थोड़ा सेप्टल वाला, दिस इज़ इंटीरियर सेप्टल, दिस इज़ पोस्टीरियर सेप्टल, राइट. सो ये सब हम प्रॉपरली ईसीजी में देखकर बता सकते हैं, और कभी ना कभी ईसीजी डिस्कस जब करेंगे तब हम ये चीज़ डिस्कस करेंगे. एंड so most commonly affected part is anterior, that is 40 to 50%. Less common is the lateral, that is 15 to 20%, and intermediate affected part is 30 to 40%, right? 30 to 40%. Then sequential pathological changes in the myocardial infarction. So first of all, so we have distinguished it in first week, second week, third week and 4 to 6 week. सो फर्स्ट ऑफ ऑल फर्स्ट वीक में फर्स्ट फ्यू आवर्स में 0 to 6 hours, दैट इज़ द विंडो पीरियड, नो चेंज इज देयर और पेलनेस कैन बी सीन, TTC NBT टेस्ट इज नेगेटिव इन द इन्फेक्टेड एरिया and light microscopy में भी no changes appeared, stretching and waviness of the fibers can be seen. Then 6 to 12 hours में भी सेम एंड जो अच्छे हॉस्पिटल्स होते हैं उसके अंदर विंडो पीरियड इज ऑफ अबाउट 12 आवर्स, ठीक है, ऑफ 12 आवर्स। तो मतलब कि हम 12 घंटे के अंदर अंदर अगर किसी को MI हुआ है तो हम उसको रिवर्स कर सकते हैं, और ये धीरे धीरे बढ़ जाना चाहिए एज पर द हॉस्पिटल्स और वो, ठीक है। And light microscopy में after in between the 6 to 12 hours we will be seeing the coagulative necrosis की beginning, and neutrophilic infiltration also begins, and edema and hemorrhages are also present. Then 24 hours में हमें क्या देखने को मिलता है, cyanotic red purple area of the hemorrhage, cyanotic red purple area of the hemorrhage, coagulative necrosis progresses and marginal neutrophilic infiltrate is there. Then 48 to 72 hours में pale and hyperemic दिखेगा, and coagulative necrosis is complete and neutrophilic infiltration is well developed. Then 3rd to 7th day में हमें क्या देखने को मिलेगा, हाइपरीमिक बॉर्डर दिखेगा विद सेंटर येलो एंड सॉफ्ट, सो आसपास में थोड़ा थोड़ा ऐसे इडीमा हो जाएगा, रेडनेस दिखेगी, और जो सेंटर में येलो होगा, राइट, and neutrophils are necrosed and gradually disappear, beginning of the resorption of the necrosed fibers by macrophages, onset of the fibrovascular response। सेकेंड वीक की 10th डे पर आपको रेड पर्पल पेरिफेरी दिखेगी, मोस्ट ऑफ द नेक्रोज मसल इन द स्मॉल इन्फार्क्ट रिमूव्ड, फाइब्रोवास्कुलर रिएक्शन मोर प्रोमिनेंट, पिगमेंटेड मैक्रोफेजेस दिखेंगे, इओसिनोफिल्स, लिम्फोसाइट्स, प्लाज्मा सेल्स आर ऑल्सो प्रेजेंट। 14th डे पर आपको सेम दिखेगा, एंड necrosed muscle जो है it will be mostly removed and neutrophils will disappear, fibrocollagenate tissue at the periphery will be seen। थर्ड वीक के अंदर भी सेम एंड ग्रॉस चेंजेस ज़्यादा चेंज नहीं होंगे, बट necrosed muscle fibers from the larger infarcts are removed and more ingrowth and fibrocollagenate tissue is developed। Then 4th to 6th week में we will be seeing a thin grey white hard shrunken fibrous scar, और एक बार मसल डैमेज हो गई तो दोबारा से डेवलप नहीं हो सकती। इंक्रीज फाइब्रोकोलाजेनिक टिश्यू, तो ये हार्डनिंग हो जाएगी और ये वाला एरिया पार्ट नहीं लेगा कॉन्ट्रैक्शंस में, ठीक है, और जो भी इसका काम है उसमें। So increase fibrocollagenate tissue, decrease vascularity, fewer pigmented macrophages will be seen, lymphocytes and plasma cells will be seen, chronic inflammatory cells आ जाएंगे। So changes in the early infarct in the electron microscope changes. So first of all, disappearance of the perinuclear glycogen granules within 5 minutes of ischemia. Then swelling of the mitochondria in 20 to 30 minutes. Disruption of sarcolemma. Nuclear alterations like peripheral clumping of the nuclear chromatin will be there. Then chemical and the histochemical changes. Analysis of the tissues from the early infarct by chemical and the histochemical techniques has shown a number of findings. First is glycogen depletion in the myocardial fibers within 30 to 60 minutes of infarction. Then increase in the lactic acid in the myocardial fibers, and loss of the K plus from the ischemic fibers, and increase of Na plus in the ischemic cells, and influx of the Ca2 plus into the cells causing irreversible cell injury. Based on above observations on the leakage of the enzymes from the ischemic myocardium, alterations in the concentrations of the various enzymes are detected in the blood of these patients. Then diagnosis, how will you diagnose? First is clinical symptoms, आप देखोगे features देखोगे। So first clinical symptom जो कि होगा, typically acute MI has sudden onset, pain will be there, sudden severe crushing and prolonged, and near substernal or precordial in location, right, unrevealed by rest or GTN nitroglycerin, and often radiating to the both of the arms, mainly left arm and neck and back, ठीक है। indigestion, pain is often accompanied by epigastric or substernal discomfort and interpreted as heartburn with nausea and vomiting, but generally ये heartburn नहीं होता, it is angina। apprehension, the patient is often terrified, restless and apprehensive due to the great fear of death। Shock. Systolic BP is below 80 mm of Hg. Lethargy, cold, clammy limbs, peripheral cyanosis, weak pulse, tachycardia, bradycardia are often present. Oliguria. Urine flow is usually less than 20 ml per hour. Low grade fever. Mild rise in temperature occurs within the 24 hours and lasts up to 1 week and accompanied by the leukocytosis and elevated ESR. Acute pulmonary edema. Some cases develop severe pulmonary congestion due to the left ventricular failure and develop suffocation, dyspnea, orthopnea and bubbling respiration. ECG changes के अंदर आपको क्या दिखेगा? ECG changes are often most prominent parameters and the most characteristic ECG change is the ST segment elevation in acute MI. Other changes include T wave inversion and appearance of the wide deep Q waves. So ST segment का elevation दिखेगा and T wave का inversion दिख सकता है and appearance of the wide deep Q waves. ठीक है. देन सीरम कार्डिक मार्कर. सो ये काफ़ी ज़्यादा रिलायबल टेस्ट माना जाता है. एंड तो क्रिएटिनिन फॉस्फेट के 3 फॉर्म्स होते हैं बेसिकली, CKMM, CKBB, CKMB. CKMB is mainly from the cardiac muscles and insignificant amount of the extracardiac tissue. Thus, the total CK estimation lacks specificity, while elevation of the CKMB isoenzyme is considerable specific for the myocardial damage. And CKMB has further 2 forms, CKMB2 in the myocardial form, while CKMB1 is an extracardiac form. Right. So certain proteins so these are certain proteins and enzymes that are released into the blood from a necrotic heart muscle from acute MI, and measurement of their levels in the serum is helpful in making a diagnosis and the plan management. And rapid assay of some more specific cardiac proteins is available, rendering the estimation of the non-specific estimation of SGOT of the historical importance only in the certain practice. And important myocardial markers in use nowadays are as under. First is creatinine phosphokinase. So CKMB is most reliable, and a ratio of CKMB to CKMB1 above 1.5 is highly sensitive for the diagnosis of the acute MI after 4 to 6 hours of the onset of the MI. CKMB disappears from the blood by 48 hours. And now comes the lactate dehydrogenase. Total lactate dehydrogenase estimation also lacks the specificity, since this enzyme is present in various tissue beside the myocardium, such as skeletal muscle, kidney, liver, lung, red blood cells. However, like CK, LDH has two isoforms, of which LDH1 is myocardial specific. Then estimation of the ratio of LDH1 is to LDH2 above 1 is reasonably helpful in making a diagnosis. LDH levels begin to rise after 24 hours and reach peak in 3 to 6 days and return to normal in 14 days. Cardiac specific troponins. Immunoassay of CTN as a serum cardiac marker has rendered LDH estimation obsolete. Troponins are contractile muscle protein present in the human cardiac skeletal muscle, but cardiac troponins are specific for myocardium. And there are 2 types of CTN. First is cardiac troponin T, cardiac troponin I. CTNT, CTNI are not found in the blood normally, but after the myocardial injury, their levels rise very high around the same time when CKMB is elevated. Then both the troponin level remain high for much longer duration, and CTNI for 7 to 10 days and CTNT for 10 to 14 days. Then myoglobin. Though myoglobin is the first cardiac marker to become elevated for the myocardial infarction, and it lacks the cardiac specificity and is secreted in the urine rapidly. Its levels thus return to the normal within the 24 hours of attack of the acute MI. Then complications. Following an attack of acute MI, only 10 to 20% cases do not develop major complications and recover. The remainder 80 to 90% cases develop one or more major complications, some of which are fatal, and the immediate mortality from acute MI uh, is about 25%, and the important complication which may develop following acute MI are as follows. First is arrhythmia. So these are the various complications that are post MI seen, and arrhythmia. So arrhythmia is the most common complication in the acute MI, right? Acute MI, and these occur due to the ischemic injury or the irritation in the conduction system, resulting in the abnormal rhythm. And other causes of arrhythmia include leakage of K plus from ischemic muscle cells and increased concentration of lactate and free fatty acid in the tissue fluid. Then arrhythmia may be in the form of sinus tachycardia, sinus bradycardia, atrial fibrillation, premature systoles, and the most serious ventricular fibrillation responsible for any sudden cardiac deaths. Then the congestive heart failure, about half of the patient with MI develop CHF, which may be in the form of right ventricular failure, left ventricular failure, or both. CHF is responsible for about 40% of the death from acute MI, and if the patient survive, healing may restore normal cardiac function, but in some, CHF may persist and require regular treatment later. Then third, cardiogenic shock. About 10% of the patient with acute MI develop cardiogenic shock, characterized by hypotension with the systolic BP of 80 mm of Hg or less for many days. Shock may be accompanied by peripheral circulatory failure and oliguria and mental confusion. Right. Now comes the mural thrombosis. Mural thrombosis and thromboembolism. The incidence of the thromboembolism from intracardiac thrombi and from thrombosis in the leg veins is 15 to 45% in the cases of acute MI, and is the major cause of death in 12% of the cases. Mural thrombosis in the heart develops due to the involvement of the endocardium and subendocardium in the infarct and due to the slowing of the heart rate. Mural thrombi often form a thromboemboli, and another source of the thromboemboli is the venous thrombus in the leg vein due to the prolonged bed rest. Thromboemboli from either source may cause occlusion of the pulmonary, renal, mesenteric, splenic, pancreatic, and cerebral arteries and cause infarcts in these organs. And now rupture of the heart occurs in 5% of the cases of acute MI, causing death. Rupture occurs most often from the infarcted intraventricular wall into the pericardial activity, causing the hemopericardium and tamponade, and other sites of the rupture are through the intraventricular septum and rupture of the papillary muscle in infarct of the left ventricle. Rupture at any of these sites occurs usually in the first week and is often fatal. Cardiac aneurysm. Another 5% of the patient of acute MI develop aneurysm. Often of the left ventricle, it occurs in the healed infarct through thin, fibrous, non-elastic scar tissue. Cardiac aneurysm impair the function of the heart and are common sites of the mural thrombi. Rarely, calcification of the wall of aneurysm may occur. And seventh is pericarditis. Pericarditis or sterile pericarditis appearing on about the second day and is common over the transmural infarct, and it is characterized by fibrinous pericarditis and may be associated with the pericardial effusion. Often it is of no functional significance and resolves spontaneously. Post-myocardial infarction syndrome. About 3 to 4% of the patients who suffer from an acute MI develop post-myocardial infarction syndrome or the Dressler's syndrome subsequently, and it is usually occurs from 1 to 6 weeks after the attack of MI, and it is characterized by pneumonitis, and the symptoms are usually mild and disappear in the few weeks. The exact pathogenesis of this syndrome is not known, and it may be due to the autoimmune reaction as evidenced by the circulating anti-heart antibodies in the serum of these patients, but these antibodies are also present in the serum of the patient with acute MI who do not develop this syndrome. Then chronic ischemic heart disease. So chronic ischemic heart disease or ischemic cardiomyopathy or myocardial fibrosis. So these are the terms for a local and the diffuse fibrosis in the myocardium, and characteristically found in the elderly patient of progressive IHD. Such small areas of the fibrous scarring are commonly found in the heart of patient who gave the history of episodes of angina and attacks of MI some years back. The patients generally have gradually developing CHF due to the decompensation over the period of years, and occasionally serious cardiac arrhythmias or infarction may supervene and cause death. Then etiopathogenesis. In the majority of the cases, coronary atherosclerosis causes progressive ischemic myocardial damage and the replacement of the myocardial fibrosis. A small percentage of cases may result from the other causes such as emboli, coronary arteritis, myocarditis, and the mechanism of the development of the myocardial fibrosis can be explained by one of the following concepts. First is myocardial fibrosis represents the healing of the minute infarcts involving the small scattered group of myocardial fibers. An alternate concept of development of the myocardial fibrosis is healing of the minute areas of the focal myocytolysis. The myocardial fibers in a small area undergo slow degeneration due to the myocardial ischemia. These fibers lose their myofibrils but nuclei remain intact. These foci are infiltrated by macrophages and eventually they are replaced by proliferating fibroblast and collagen. And morphological features. Grossly, the heart may be of normal in size or hypertrophied, and the left ventricular wall generally shows foci of the gray-white fibrosis in the brown myocardium. Healed scars of the previous MI may be present, and valves of the left heart may be distorted and thickened and show calcification. Coronary arteries invariably show moderate to severe atherosclerosis, and microscopically the characteristic features are as follows. There are scattered areas of the diffuse myocardial fibrosis, especially around the small blood vessels in the interstitial tissue of the myocardium. Intervening single fiber and the group of the myocardial fiber show variation in the fiber size, foci of the myocytolysis, and areas of the brown atrophy of the myocardium may also be present. Then coronary arteries show atherosclerotic plaques and may have complicated lesions in the form of superimposed thrombosis. Then hypertensive heart disease. Hypertensive cardiomyopathy is the disease of the heart resulting from the systemic hypertension of prolonged duration and manifesting by the left ventricular hypertrophy. Even mild hypertension of sufficient duration may induce hypertensive heart disease, and it is the second most common form of the heart disease after IHD. As already pointed out, hypertension predisposes to the atherosclerosis, and therefore most patients of hypertensive heart disease have advanced coronary atherosclerosis and may develop progressive IHD. Amongst the causes of the death in hypertensive patients, cardiac decompensation or cardiac remodeling leading to the CHF, and this accounts for about 1/3 of the patients, and other causes of the death are IHD, cerebrovascular stroke, renal failure following the arteriolar nephrosclerosis, dissecting aneurysm of the aorta, and sudden cardiac death. Pathogenesis of the left ventricular hypertrophy, which is the most commonly caused by systemic hypertension, is described here, and here we will be discussing the how the left ventricular hypertrophy is caused due to the systemic hypertension and how this hypertrophy leads to the failure. So stimulus to the LVH is the pressure overload in the systemic hypertension. This you know, and this we have discussed in our last class and this class. Both the genetic and hemodynamic factor contribute to LVH or left ventricular hypertrophy. The stress of the pressure on the ventricular wall causes the increased production of the myofilaments, myofibrils, and other cell organelles and nuclear enlargements. Since the adult myocardial fiber do not divide, the fibers are hypertrophied, and therefore the sarcomeres may divide to increase the cell width, and LVH can be diagnosed by ECG. Then aggressive control of hypertension can regress the left ventricular mass, but which antihypertensive agent would do this in addition to their role in controlling the blood pressure is not clearly known, but yes, we know the remodeling is due to the aldosterone, and we can block the renin and we can block this hypertrophy. So beta blockers are there, direct renin inhibitors are there, so we know all the drugs, right? And abnormalities of the diastolic function in the hypertension is most common, are more common in the hypertension, and is present in about 1/3 of the patient with the normal systolic function. Morphological features. Grossly, the most significant finding is marked hypertrophy of the heart and chiefly of the left ventricle. the weight of the heart increases to 500 gram or more, and the thickness of the left ventricular wall increases from its normal 13 to 15 mm to 20 mm or more, and the papillary muscles and the trabeculae carneae are rounded and prominent here. Initially, there is concentric hypertrophy of the left ventricle without dilatation, but due to decompensation and the cardiac failure supervenes, there is eccentric hypertrophy with the dilatation and with the thinning of the ventricular wall, and there may be dilatation and hypertrophy of the right heart as well. Microscopically, the features are not prominent as gross appearance, and the change include enlargement and the degeneration of the myocardial fibers with the focal areas of the myocardial fibrosis. In advanced cases, there may be myocardial edema, foci of necrosis in the myocardium. Then core pulmonale, we have already discussed the core pulmonale. I have already told you the pathogenesis of the core pulmonale, but let's discuss it again. So, core pulmonale or a pulmonary heart disease, so it is also called as pulmonary heart disease. So due to pulmonary or due to lungs, heart is damaged, right? And pulmonary heart disease is the disease of the right side of the heart resulting from the disorders of the lungs. It is characterized by the right ventricular dilatation or hypertrophy or both. Thus, core pulmonale is the right-sided counterpart of the hypertensive heart disease just described, and depending upon the rapidity of the development, core pulmonale may be acute or chronic, and acute core pulmonale occurs following massive pulmonary embolism resulting in sudden dilatation of the pulmonary trunk, conus, and right ventricle. And chronic core pulmonale is more common and is often preceded by the chronic pulmonary hypertension, and following chronic lung disease can cause chronic pulmonary hypertension and subsequent core pulmonale. Chronic emphysema, chronic bronchitis, pulmonary TB, pneumoconiosis, cystic fibrosis, hyperventilation in marked obesity, multiple organized pulmonary emboli. And what is the pathogenesis? So chronic lung disease as well as diseases of the pulmonary vessels cause increased pulmonary vascular resistance. The most common underlying mechanism causing the increased pulmonary blood pressure is by pulmonary vasoconstriction, activation of coagulation pathway, and obliteration of the pulmonary arterial vessels. Pulmonary hypertension causes the pressure overload on the right ventricle, and hence the right ventricular enlargement is there. Initially, there is right ventricular hypertrophy, but as the cardiac decompensation sets in, the right heart failure ensues and dilatation of the right ventricle occurs, right? And yeah, that was the pathogenesis of the core pulmonale. And now we have the rheumatic fever, and we will be discussing the rheumatic fever in the next session. एंड एक बार फटाफट से देख लेते हैं कि अभी तक हमने क्या क्या पढ़ लिया है, एंड देन वी विल बी एंडिंग दिस सेशन हियर. सो गाइज, हमने सिस्टेमिक पैथोलॉजी स्टार्ट करी थी, ठीक है. सिस्टेमिक पैथोलॉजी एंड आर्टरीज डिस्कस कर ली थी फिजियोलॉजिकली. देन आर्टरियोस्क्लेरोसिस, सिनाइल हाइपरटेंसिव, मॉन्कीबर्ग, एथेरोस्क्लेरोसिस, where Monckeberg's is very important. Atherosclerosis is also a very important topic. Then हमने atherosclerosis को अच्छे से इसका फिनोमेना सब देख लिया था. एंड फिर हमने वैस्कुलाइटिस स्टार्ट करी थी, एंडार्ट्राइटिस, ऑब्लिटरेंस, सिफिलिटिक एओर्टाइटिस, पॉलीआर्ट्राइटिस नोडोसा, वेगनर्स ग्रेनुलोमाटस, then temporal arteritis or giant cell arteritis, and Takayasu arteritis, Kawasaki disease, Buerger's disease, Raynaud's phenomena, and Raynaud's disease, एनोरिज्म, एथेरोस्क्लेरोटिक एंड डाइसेक्टिंग एनोरिज्म. एंड उसके हमने वो देख लिए थे क्लासिफिकेशन. वेरिकोज वेन्स देख लिए हैं, थ्रोम्बोफ्लेबाइटिस देख लिया है, कैपोसी सार्कोमा देख लिया है, एंड कंजेनाइटल हार्ट डिजीजेस देख लिया, मैल पोजिशन डेक्स्ट्रोकार्डिया एंड साइटस इन्वर्सस देख लिया, लेफ्ट टू राइट शंट देख लिया, VSD देख लिया, ASD देख लिया, एंड पेटेंट डक्टस आर्टिरोसस देख लिया, लेफ्ट टू राइट शंट देख लिया, टॉफ के बारे में अच्छे से पढ़ लिया, साइनोटिक टॉफ और एसाइनोटिक टॉफ देख लिया, ट्रांसपोजिशन ऑफ ग्रेट आर्टरीज देख ली, पर्सिस्टेंट ट्रंकस आर्टिरोसस, दैट इज अ रेयर कंडीशन, वी हैव ऑलरेडी डिस्कस्ड, ट्राइकस्पिड एट्रीसिया एंड स्टेनोसिस. देन ऑब्स्ट्रक्शंस के अंदर कोआक्टेशन ऑफ एओर्टा, एओर्टिक स्टेनोसिस एंड एट्रीसिया, पल्मोनरी स्टेनोसिस एंड एट्रीसिया. And now heart failure, we have discussed the etiology, increased workload, प्रेशर लोड, वॉल्यूम लोड, देन एक्यूट एंड क्रोनिक हार्ट फेलियर के बारे में बात करी, राइट एंड लेफ्ट साइडेड हार्ट फेलियर के बारे में बात कर ली, बैकवर्ड एंड फॉरवर्ड हार्ट फेलियर के बारे में बात कर दी, एंड वी हैव ऑलरेडी डिस्कस दीज थिंग्स। डन। कार्डियक हाइपर रीमॉडलिंग की बात कर ली, हाइपरट्रोफी एंड डायलिटेशन की बात कर ली, इस्कीमिक हार्ट डिजीज स्टार्ट करा था, इटियोपैथोजेनेसिस स्टार्ट करा, देन हमने उसके कॉजेज देखे, फिर उसका प्रोग्रेशन देखा, एंजाइना के बारे में उस और टाइप्स ऑफ एंजाइना डिस्कस करे, देन हमने देखा टाइप ऑफ इन्फैक्ट्स, उसके बाद हमने पैथोलॉजिकल चेंजेस देखे, एमआई में ग्रॉस चेंजेस, लाइट माइक्रोस्कोपी में क्या क्या चेंजेस दिखते हैं, देन हाउ वी कैन डायग्नोज द पेशेंट, फिर हमने कार्डियक मार्कर्स भी देखे, देन कॉम्प्लिकेशंस डिस्कस करी, एंड देन क्रोनिक इस्कीमिक हार्ट डिजीज़ के बारे में बात करी, देन हाइपरटेंसिव हार्ट डिजीज़ के बारे में बात करी, कोर पल्मोनल के बारे में बात करी, एंड रोमेटिक फीवर के बारे में हम नेक्स्ट क्लास में बात करेंगे। And thank you so much guys for coming, and we will be discussing this topic in the next session, and I'll be meeting you soon. Bye guys, take care, stay healthy, stay positive, stay safe,